Good afternoon. Today's lab is going to be positioning of the fingers, hand, and wrist. We will have the patient in the seated position at the end of the table. As you can see, our patient already has lead on. Lead is for their protective excess radiation not being applied to any body part. We will use a 10 by 12 inch cassette resting on the table top. We will maintain a 40-inch SID from our tube to our IR. The first position that we're going to demonstrate is with the thumb. Most of the digits are done in the similar fashion. The thumb being your very first digit and your pinky being your fifth digit. The thumb is the only digit that we do in the AP projection. For digits, we will utilize the entire IR. We will put the body part as close to the center of the IR as possible, and we will divide the IR into 3 separate sections. This is one of the only images that we will actually put all 3 positions on one IR. You will always have either the PA or the AP on either end, the lateral on either end, and the oblique will always fall in the middle. So let's start with the first digit. We will have the patient turn their hand so that the thumb is actually in the AP position. You can always turn your collimator box to reach exactly where you need to be. The central ray placement for the first digit is at the MCP, the metacarpal phalangeal joint. And as you can see, this is where our central ray placement is. We do need to include accessory markers. We have a left, which we will place right here. And we also have a 1, which we will also place here. You may use lead strips to minimize the excess scatter radiation that will happen from your image. From here, we will make our exposure. When we come back from making this exposure, you can have your patient just relax, and you can still see where the light field is. I've also indicated the edge of the light field with this left marker. We will pick the lead strip up, slide the IR to the unexposed part, place the hand back. You only need to mark one of the positions. So we do not need to continually mark the left side and the first digit. The hand just rests in its natural position. Central ray placement is still at the MCP. And as you can see, we could collimate just a tiny bit more because we are eliminating the markers on this image. This is for your oblique first digit. Again, you can add the lead stripping if you like. We have stayed within the middle of the IR. Our third image would be for the lateral. The patient will now just simply take their hand, rotate it up to the side. If it's uncomfortable for the patient like that, they can roll their fingers down, kind of keep their hand in a nice lateral position. Central ray is still at the MCP and the long axis of the finger. We'll make this exposure, and that concludes the positioning for the first digit. We'll now move on into the second digit. We've obviously gotten a new IR. Now the second digit is the index finger. So we are going to put this image in the center of our IR. Just try to fan the fingers out briefly so that we do not have overlappingness of the digits. The central ray placement for the second digit is at the PIP joint and long axis of the finger. So again, you're going to mark, this is the left, it is the second digit. So we'll put the 2 in there so that the radiologist will know that this is the the second digit. As you can see, we have utilized the PA on the far end, the oblique again will be in the middle, and the lateral will be on the other side. After we have made this exposure, we will just slide the light field to the center of the cassette. At this time, there are different ways to oblique the hand to minimize the OID. So we will oblique the hand medially, and the other 3 digits we will oblique laterally. So we will oblique the hand this way to minimize the OID, which is the object to image distance. Again, the central ray placement stays the same at the PIP joint. Since we have marked our first image, we no longer need to mark the sequential ones. From here, and the hand is obliqued at a 45-degree obliquity. If the patient cannot hold this position, you may always use a wedge sponge if your facility happens to have one. So the patient will have their hand placed on the sponge. The central ray placement is still at the same area, and we will make the exposure for this image. The last position that we will do is the lateral, and as you can see, she has rotated it medially. The PIP joint and long axis, the finger is nice and extended. All of the other digits are tucked in. This is really the only digit that we are focusing on at the moment. And as you can see, the light field is from the tuft, including the tuft, all the way towards where the metacarpals are. This would be the lateral position for the second digit. Now, I will demonstrate the 4th digit, which is just a little bit different. Again, we will now have a clean IR. So the 4th digit, we are going to rotate this one just a tad bit differently. It will be rotated laterally. Again, that is easier for the patient, and it eliminates as much of the OID as possible. We have placed, you can see that the digit is what is placed in the center of the IR. This is for aesthetic purposes and easier to read. You don't want one image here, another one up here, and the other one down there. You're just reading straight across all of the positions that we have shot. For the 4th digit, we will have the central ray placement again at the PIP joint of the 4th digit and the long axis of the finger. We will indicate that this is the 4th digit. This is the left side, and we would utilize any of our lead shielding to minimize scatter to the other parts of the IR. From here, this is our PA position for the 4th digit. We will then remove our markers, slide the light field to the middle. We will oblique our digit laterally this time. Separate the opposing digits so that we really just try to focus on this one as much as possible. The central ray placement is still at the PIP joint and long axis, which is exactly where it is. Since we labeled and marked the first digit and the first image, we do not need to do it on this one. This is the oblique of the 4th digit. From here, we will move over to do the lateral. Now the lateral, if it's very difficult for the patient to tuck all these fingers in and to extend this one out, usually that ring finger is a little more difficult. We can utilize some additional supplies. You can always utilize your wedge sponge if your facility happens to have this. They may not. They could just rest the finger right there. That supports it. If they do not have a wedge sponge, you may use a tongue depressor. We don't want to use any metal objects. The metal will show up. So you can have your patient extend this finger outward and just hold the tongue depressor so that their finger is extended and all of the other digits are tucked in. As you can see, we still have our central placement right here on the PIP. Her opposing hand is out of the light field. We're not going to see that. We may see a little bit of a difference in density for the tongue depressor, but it will not obstruct any of the visualization of this bone. This is the lateral projection of the fourth digit. Continuing on in our positioning of the hand, we will still be using the 10 by 12 inch IR. We're now going to position for the hand. On this particular body anatomy, we only place one position on one IR, okay? And as you can see, we have the hand and the arm all on the same plane. That's how we'd like to keep it. We don't want any deviation of the wrist or the arm or the hand. We would like for it to all be nice and flat, and it should be at a comfortable level of the patient. You don't want the patient lifting up here or really squatting down to put their hand in. So for the hand, we're going to have the patient just place their hand in the middle of the IR. You're going to have their digits moved just slightly. We will have all obscuring objects removed, if possible. No rings, no watches, no bracelets, none of that. Obviously, if they've had some sort of a trauma and they cannot remove a ring, then it's noted on the requisition, unable to remove jewelry. So from here, our patient is still leaded, completely protected. We're going to have the central ray placement will be at the third MCP, okay? This is the third digit at the metacarpophalangeal joint and long axis of the hand. You always have 2 points of intersection for your central ray placement. And as I said, we'll try and fan the fingers out. We just don't want them all bunched up together. We want to see the digits separately. Obviously, if there's some sort of a trauma, you do the best you can. Make sure that you label with your appropriate marker. And we want to collimate to skin margins. Make sure that you do not clip the distal tufts of the fingers. This includes about 1/3 of the wrist on your image. So this is the positioning for the PA hand. After we have made this exposure, the next position in the series is an oblique hand. Again, we'll have a new IR. The oblique hand, there are 2 different ways to shoot the oblique hand. You will see many technologists just kind of rotate the patient up, kind of make an OK sign. This works fairly well. It does not open up the digits as best as possible. We really just want the entire hand to be obliqued at a 45-degree obliquity without these digits resting, because then that closes up these joint spaces. Again, if you happen to have a wedge sponge, you can certainly utilize that. You'll have the digit on the cassette or the IR and each finger resting on a part of the sponge. And then you can see here the entire hand is obliqued, not just the last 3 digits and the first 2 are completely closed off. If you do not have a sponge, then just have the patient rotate their hand up to about a 45-degree obliquity. We try to fan out the fingers. The central ray is going to be at the same place, which is right here. Since one image is on each specific IR, you need to make sure that you mark each specific image. This is the oblique hand. After we have made this exposure and we have gotten a new IR, we will move into the lateral. It is very important that the radius and the ulna are superimposed. So you want to palpate at the wrist, make sure that there is no obliquity forward or backwards. Try and really make sure that the wrist is nice and superimposed. Many facilities will ask that you do what we call a fan lateral, where the fingers are spaned out as closely away from each other as possible. Again, this is for the hand, so we want to see the entire digits as well. Now, being that we are doing the hand, the central ray placement is at the second metacarpophalangeal joint. We can't get here. It makes sense to put the CR here. and long axis of the hand. We will collimate in without clipping any pertinent anatomy. Have your patient try and hold as still as possible. And this is the fan lateral hand. You will have some facilities that just do what we consider kind of a karate chop. This is certainly not as advantageous for demonstrating the digits, but if you do, it would look something more like this. Central ray placement is at the second MCP joint and long axis. The position of choice is the fan lateral. These are the positions for the hand. The wrist varies just slightly from the hand, and we will demonstrate those now. For the wrist, the central ray placement moves, and we also have the patient curl their fingers towards the IR. What this does is it limits the OID here of the carpal bones. The central ray placement is mid-carpal bones and long axis. They're not balling up their fist or making a tight fist. That moves all of these bones and joints in here. It's just a very simple curling of the fingers, and as you can see, this flattens out right to the IR. We do not need to include anything except from the carpals and the metacarpals to a little bit of the wrist. So we can cone in to about so. And this is for your PA wrist. And as you can see, the collimation is much tighter for this view. Again, after the exposure, we are going to get a new IR. We will have the patient oblique their entire hand, forearm, and wrist to a 45-degree obliquity. Central ray placement is again at the same area, mid-carpal bones and long axis. Your marker is necessary, and we may collimate in to a tighter area since we have obliqued the patient. Their hands can be curled in or they can be left out a little bit, whatever happens to be comfortable for the patient. And then from this position, with a new IR, they go all the way up into the lateral, again making sure that the radius and the ulna are superimposed. You can palpate for those styloid processes, make sure that they're overlapping. Central ray placement will be right at the mid-carpal bones and long axis. Marker is included, collimation is appropriate, and the exposure will be made. These are the positions for the PA hand, oblique hand, lateral hand, the PA wrist, oblique wrist, and the lateral wrist. We will now demonstrate two special views of the wrist. One is the scaphoid or navicular shot. And that is really to demonstrate the navicular bone. That happens to be one of the most common fractured bones in the wrist. At this time, we will have the patient, I'm just going to turn her a little bit so that she is actually on the end of the table. She is going to place her hand and wrist on the IR, and she is going to gently, without making any sharp movements, just deviate her wrist towards her ulna side. What that does is that really just kind of takes that scaphoid and sticks it out so we can view this a little bit better. This is going to need an angulation of our tube. So we will put a 10-degree angulation onto our tube. We're still going to maintain the 40-inch SID. And instead of going to the mid-carpal area of the wrist, we're actually going directly aiming for the scaphoid bone. So the angulation is towards the elbow or proximally so that we can just really elongate this bone, look at it really elongated and sticking out so that we can really focus primarily on that bone. We still include the rest of the carpal bones since we are doing a wrist. So here is your central ray placement with an angulation on your tube of 10 to 15 degrees, and it's directly centered towards the scaphoid bone and long axis. After we make this exposure, this is a special view of the wrist. Okay. Sometimes that may be very difficult for the patient to do, especially if they have a fracture or there any kind of tendonitis that's going on in there. The next view that we're going to do is the carpal canal or the carpal tunnel view. This view is also generally very difficult for your patient to do, especially if they have had any kind of carpal tunnel issues. Hands tingling, fingers tingling, unable to hold things, grasp them accordingly. So this time, again, we have an angulation on our tube. It's significantly more. It's about a 30 to a 40 degree angulation on our tube. We're going to utilize some areas to help us with the position. The patient is placed at the edge of the table. Their arm, their wrist, and their hand is placed this time a little above the center of the cassette or the IR. We're going to be projecting the image more towards the distal end. So we want to make sure that we put our body part more towards the proximal end. This is a tourniquet that we can utilize. The patient is going to flex, hyperextend their hand back. We don't want them to lift their wrist up off the IR. We want to try and keep it down there as much as possible. Okay, and we're also going to, after we have this, they have hyperextended backwards. They're going to rotate their hand just slightly, about 5 to 10 degrees towards the radius. The central ray placement is going to be at the third MCP and long axis of the hand. What this is going to demonstrate for us is just the entire carpal canal. And as you can see, maybe or maybe not, the central ray placement is right here. It's about 2 to 3 inches distal to the MCP of the third digit, which is about right there, and long axis. The patient is hyperextended, rotated just about 10 degrees towards the radius with a 30 to 40 degree angulation of our tube. This is the carpal tunnel or the carpal canal position. This concludes all of the positions for the fingers, hands, and the wrist.